Thank you so much, Mr. Chaitanya, for your kind introduction. And very good evening, my dear doctors, professional colleagues. So, this is Dr. Sepuri Krishnamohan, senior endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Kurnool. So, today we'll be talking about the triple drug combination per se, that is the one, the metformin, basically the drug of choice for type 2 diabetes unless otherwise it is contraindicated or it is not tolerated by the patient. So to that metformin we are adding one SGLT2 inhibitor and one DPP4 inhibitor, but thereby making it a ideal triple drug combination for the newly detected type 2 diabetes patients. This is called the spectrum by Dr. Reddy's people, and thank you, Dr. Reddy's, for giving me the opportunity to be the speaker of this evening. And let's get into the slides. And today's topic is the importance of accessible and affordable diabetes care in India. Focus on triple drug therapy in type 2 diabetes. See, earlier triple drug was different. So when the days were totally different. The triple drug started with this particular the glibenclamide, metformin, and rosiglitazone. Later on, after the rosiglitazone is gone out of India, so we had the multiple combinations with one sulfonylurea, metformin, and the pioglitazone drug belonging to the thiazolidine dienes. So that was called a triple drug in the anti-diabetic therapy. Likewise, a triple drug means in antihypertensive therapies, one ACE or ARB, one calcium channel blocker, one this particular diuretic, thiazide-like diuretic, that is called the chlorthalidone. See, that is the triple drug therapy in hypertension. But the advances have taken place, and many new drugs have come in the armamentarium of diabetes mellitus. Especially, I am referring it only to type 2 diabetes mellitus. So it is now the latest triple drug means not the sulfonylurea plus metformin plus glitazone. No. Now this is the metformin plus the DPP4 inhibitor and the SGLT2 inhibitor. See, focus on triple drug therapy in type 2 diabetes. Yes, managing the diabetes in uncontrolled patients can be a load in a clinical practice. So, especially country like India, it's a major burden because most of the cases suffering from type 2 diabetes are in the productive period. So that's a huge menace as far as the loss of working hours plus the expenditure towards the management of the diabetes mellitus, type 2 diabetes mellitus, and the load in achieving HbA1c goals and managing the hypoglycemia and minimizing the future complications and pill burden. Pill burden is always a problem because multiple pills you have to take and multiple times you have to take, and as you grow elderly because of the presenile dementia or because of the Alzheimer's disease, you tend to forget to take one or two pills because that is called polypharmacy. Polypharmacy is always, the pill burden is always a problem which reduces the patient's tolerance and compliance actually. So the greatest advantage of this the triple drug combinations is that the patient can never forget to that one tablet in the morning after breakfast, that's enough. So the pill burden can be reduced, the polypharmacy can be reduced by getting FDCs, that is fixed dose combinations of this particular drugs. And diabetes care, a health priority in India. India is at the forefront of countries grappling with the socio-economic burden of the diabetes. And currently, see, this figure is little bit misleading actually. The we don't have the latest census as on 2022. The current individuals suffering from type 2 diabetes is around 212 millions according to this International Diabetes Federation 10th atlas actually. So the number of people with diabetes is projected to 134. Not this is not correct. It will be somewhere around some 350 to 400 million by 2045. A study conducted in 15 states of India reported that the mean prevalence of prediabetes in India is 10.3%, which is very, very alarming. See, because prediabetes is very important as far as it is related to the increased risk of the cardiovascular morbidity and mortality. It is almost equal to that. The diabetes and prediabetes are the similar as far as the cardiovascular mortality and morbidity are concerned. So we need to be very cautious. We need to pick the patients at the stage of prediabetes, so that we can minimize the cardiovascular complications, and we can see to that they don't just get into the overt type 2 diabetes also. So more than 1 million deaths in India related to diabetes and its associated complications. This is per annum actually. So the several challenges contribute to diabetes among Indians. The unawareness about the diabetes and its complications, and inadequate healthcare facilities and lack of access, and healthcare expenditure actually, and non-adherence to the treatment, and lack of accountability. On top of it, I want to add one more thing is the inertia, that is the therapeutic inertia, which is the biggest challenge in our scenario, Indian scenario, where the doctor doesn't respond properly at the right time, when to start insulin, when to start this the triple drug combination and all. That is called the therapeutic inertia. And even the doctor counsels the patient and the patient doesn't listen to the doctor, that is called the patient's inertia. So delivering accessible, affordable and high quality care are some of the major challenges of diabetes care in India. So the glycemic control pattern seen in India using different glycemic parameters, the HbA1c or the fasting or the random or the postprandial blood glucose. So on the left hand side we can see the bar diagram, and on the first you can see this the HbA1c. See the blue bit shows that the patients around 21% patients are around or less than 7% of HbA1c, and the green is it is more than the around or more than 10% of A1c, which accounts for 15%, and in between the red, the huge chunk is in between these two parameters, that is the HbA1c, which is shown in red, that is starting from more than 7 to 10% of HbA1c. And the glycemic control status, you can see the bar diagram. The controlled is the fasting around or less than 125, the postprandial around or less than 180 milligram per deciliter, and the random blood sugar or the casual plasma glucose around or less than 200 milligrams, and with an A1c of around or less than 7%. The uncontrolled are the almost, see if it is more than the fasting being more than 126, the post lunch being more than 181 milligrams per deciliter, and the casual plasma glucose more than 201 milligram per deciliter, and the A1C more than 7%. So, but A1C and the glycemic triad, what we call generally, the fasting plasma glucose and the 2-hour post glucose and the HbA1c are called glycemic triad. So they differ. There are certain relaxations, mainly being the age. The patients who are above 70 years of age can have 7.5, even that is very much normal, and 80 is normal. A1C of 80 is very much normal. So if you see the bar diagrams, you can see the fasting blood sugar, the less than the control group is like, okay, the patients who are totally controlled, the fasting blood sugars, it's around some 30%, whereas the 70% are not controlled. Likewise, the postprandial 55%, 55.5% are at control, 44.5% are uncontrolled, and the random blood sugars 51.7% are at control, and the 48% of they are uncontrolled. And when coming to HbA1c, only 20% are to the target, and the rest of 80% is not to the target. That is, they are around more than 7, not around. A total of 336 prescriptions written for the diabetes were analyzed. 79% were not controlled, taking a cutoff of HbA1c of around the less than 7%, and mean HbA1c was found to be 8.3, and mean fasting blood sugar and the random blood sugar and the postprandial blood sugars were 168.74. So that shows that it is not controlled put together. So the real evidence confirms that the Indian population with type 2 diabetes has got a high burden of poor glycemic control. More than 50% of the individuals with diabetes have poor glycemic control, A1C more than 8%. We have seen there the red bit is around 7 to 10% is having the huge chunk of more than 60%. And uncontrolled hypertension and uncontrolled dyslipidemia, that is the poor ABC, the poor A1C, the poor blood pressure, and the poor cholesterol, that is uncontrolled hypertension and uncontrolled the dyslipidemia and the vascular complications. And this is the ADA 2025 algorithm for management of type 2 diabetes that recommends a person-centered sharing decision-making approach to guide the choice of glucose-lowering medications for adults with type 2 diabetes mellitus. So you can download this slide from the Google net that is given in the ADA guidelines 2025. That is, you can get it from the journal Diabetes Care volume 1, that is the January 2025 is nothing but there won't be any article in that. Every year the first Diabetes Care, that is the month of January, is the recommendations. That's all the recommendations related to all the changes that have been made will be updated in this thing. Like you can see, it's a busy slide which is not visible. So the goal, the cardiovascular and the kidney risk reduction in high risk individuals with type 2 diabetes, it is our goal. So and that on top of it, if you have the atherosclerotic cardiovascular disease, or you have indicators for high cardiovascular disease risk, you can go for the GLP-1 receptor agonist with the proven cardiovascular benefits, or the SGLT2 with proven cardiovascular benefits. And the third arrow shows the presence of heart failure. So whenever there is predominant atherosclerotic cardiovascular disease, the GLP-1 receptor agonists or the SGLT2 inhibitors are the drugs of choice. or when the heart failure predominates, the SGLT2 inhibitors are the drugs of choice. And whenever there is CKD actually, and you can have the SGLT2 inhibitors, the nowadays the maximum tolerated dose of ACE or ARB is the first drug of choice, and followed by SGLT2 inhibitor, and nowadays we are using even finerenone for that. It's a non-steroidal mineralocorticoid receptor antagonist, and the goal is achievement of and maintenance of the weight and glycemic goals. When you want to maintain the weight, you need to go for the efficacy for weight loss. Drugs like the GLP1 receptor agonists like the semaglutide and the tirzepatide, they are the once a week subcutaneous injections which belong to the group of GLP1 receptor agonists. So that is the drug of choice, and even the SGLT2 inhibitors also they have a very good reduction, but the maximum reduction is seen with this particular the GLP1 receptor agonist. And the achievement and maintenance of glycemic control, you can use metformin and the other agents, and the dulaglutide can be used, semaglutide can be used, tirzepatide, even the liraglutide can be used. The combination therapy can be considered in adults with type 2 diabetes at the initiation of the treatment to shorten the time and attainment of individualized treatment goals. This is the level of recommendation is level A, and the treatment modification and intensification and disintensification for adults not meeting individualized treatment goals should not be delayed. That also is level A recommendation. And the initial combination therapy should be considered in people presenting with A1C levels of 1.5 to 2% above their individual goal. So these are the latest recommendations according to the treatment algorithm for type 2 diabetes according to the American Diabetes Association 2025 recommendations. And this slide shows the suggested patients features for initial combination therapy, where the initial evaluation of the patient feature, like on the left hand side, the high probability of being controlled with monotherapy, and on the right hand side you can see that the high probability of requiring initial combination. Actually the A1C is around 7 to 7.5%, and then the multiple parameters taken here are the A1C, the age, BMI and the motivation. This is a shared decision with the patient. Always the treatment is, I define treatment as the gentleman's agreement between the doctor and the patient. You should discuss with the patient the pros and cons of the treatment which you are going to initiate. Let it be OADs or the insulin, whatever it may be, the GLP1 receptor agonist, whatever it may be. You need to inform the patient that I am going to start this particular type of treatment, which may benefit you in so and so ways. So that is the agreement between the patient and the doctor. Therapeutic guidelines recommend treatment intensification through addition of anti-diabetic agents for patients with inadequate glycemic control with metformin. However, the dual add-on therapy is rarely used, despite the knowledge that glycemic control is seldom achieved with single agent add-ons. This is called the inertia. The therapeutic inertia is that we know that the patient can never be controlled with a single drug, but still we write only single drug, that is metformin, to start with. The favorite molecule being the glycomet SR 500, glycomet or plain glycomet or glycomet 1 gram, that's all. We pretty well know that metformin, the longevity and the sustainability of the metformin is not beyond 3 years if it is started alone, and it doesn't get back to the glycemic triad to the normalcy at any cost. But still, knowingly, we don't go for combinations. See, recently I'll tell you, The verified trial has come with the metformin in combination with the vildagliptin. So the inference, the results rolled out in 2019 EASD scientific sessions actually, September 2019. So the inference taken is the longevity and the sustainability and the efficacy of the metformin can be maintained up to 6 years. Instead of 3 years, you can maintain it for 6 years if it is combined with this particular molecule vildagliptin. So the inference is, the broad inference is, it is done with vildagliptin because the sponsors were the Novartis people, the original researchers of vildagliptin. What I mean to say is, you like any gliptin except 10-gliptin, please never ever write 10-gliptin, and which has got some serious cardiovascular side effects, which increases the QTc interval that leads to ventricular arrhythmias and sudden cardiac arrest and sudden cardiac death. Barring that, you can go for the vildagliptin or the sitagliptin or the linagliptin also. Now it is off patented. They are available at very economical price, even cheaper than the 10-gliptin actually. So select a very good molecule without any complications. So however, dual add-on therapy is rarely used despite the knowledge that the glycemic control is seldom achieved with single agent add-ons. The use of single agent add-ons often leads to the long periods of hyperglycemia, which are associated with the increased the morbidity. And the incidence of the complications, either the macrovascular complications or the microvascular or the macrovascular complication, they also raise parallel to the hyperglycemia. The landmark clinical trials on the management of type 2 diabetes have reported that intensive glycemic control reduces the risk of the microvascular complications. Per se, it is a known fact that you stringently control the blood sugars and the euglycemia is maintained. The microvascular complications, they go parallel to the euglycemia. The intensive glycemic control in the early period of diabetes leads to a significantly lower incidence of macrovascular complications. Because macrovascular complications are not only dependent on glycemia but various other factors. There are a lot of factors like not only the diabetes, the comorbidities like the hypertension, the dyslipidemia, this sedentary lifestyle, the physical inactivity, and overeating, that is affluent eating, obesity, overweight, and the lipoprotein little a and the ApoB, and the family history of heart disease, the family history of the strokes, and there are so many things like smoking and also the alcohol. It is multifactorial in origin, whereas the microvascular complications of diabetes are confined to the glycemic control. So the international consensus has recognized the need for combination therapy for the glucose lowering in patients with high HbA1c levels. And this slide shows us the clinical evidence on the role of initial triple drug therapy in type 2 diabetes with focus on the SGLT2 inhibitor plus DPP4 inhibitor plus metformin. All the time remember, in treating type 2 diabetes, metformin should be the first drug of choice unless otherwise is it contraindicated or it is not tolerated by the patient. So in combination with the DPP4 or with the SGLT2 inhibitor or with the sulfonylurea, you can come up with so many combinations which are available in the market. The 3-year follow-up of the EDIC trial confirms the long-term efficacy of initiating triple drug therapy in patients with new onset type 2 diabetes mellitus versus conventional sequential therapy. You can clearly see on the left hand side the graphic representation, the black showing the conventional therapy and the dotted empty ones that shows the triple therapy. You can very clearly see that the conventional therapy is not able to get back to the normalcy, whereas the triple therapy is much more efficacious and it is able to bring down the this particular the A1C levels. And on the right hand side you can see the more participants receiving the triple drug therapy achieved and maintained the treatment goal compared with those receiving conventional therapy. And the black is the conventional therapy and the triple drug is the conventional therapy. You can see the p value, it is 0.0002, that is which is statistically very significant. So the inference is the combinations are much more better than the single therapy. That's what. Initiating triple therapy in patients with the new onset type 2 diabetes mellitus improves insulin sensitivity and beta cell function multifold. You can clearly see in these bar diagrams the triple therapy on the left hand side and the conventional therapy on the right hand side. You can see the difference on the left hand side, the comparative bar diagrams, and also the conventional therapy on the next bar diagram shows the triple therapy is very efficacious when compared to, and both are statistically very significant. At the end of 3 years, the triple drug therapy produced a 3-fold increase in the insulin sensitivity and 30-fold increase in the beta cell function compared to the conventional sequential therapy. Sequential is nothing, they are starting with one drug, after 3 months or 6 months adding the second drug, titrating the dose, and again adding the third drug, again adding the fourth drug. It goes on like this. See, they always remember, after 3 drugs, the next drug should be insulin. Or the baseline A1C is around or more than 9 also, the drug of choice is insulin. So the early intensification to triple therapy results in better and more durable glycemic control than the dual therapy in patients with, always you remember, triple drug therapy is more superior to dual drug therapy. Dual drug therapy is more superior to monotherapy. That's what. In patients with high HbA1c levels who are uncontrolled with metformin monotherapy. And the sustained 52 weeks glycemic efficacy of triple drug therapy is not associated with an increased risk of hypoglycemia compared to the dual therapy, because metformin per se doesn't cause hypoglycemia, and the same is with DPP4 inhibitors and same is with SGLT2 inhibitors. So most of the times they don't cause hypoglycemia, and that too especially the nocturnal hypoglycemia. That too level 3 hypoglycemia is rarest of the rare. You can never find a level 3 hypoglycemia or the nocturnal hypoglycemia with this combination. So this is the best aspect of this triple drug therapy, the metformin and the DPP4 inhibitor and the SGLT2 inhibitor. So they rose without thorn. That's what it is. So the summary of the adverse events over 52 weeks of treatment, and you can see the incidence of hypoglycemia. The triple drug or the double drug, it is more or less same. And hypoglycemia leading to discontinuation of study during the study period, it is 0 in the both arms. And effectiveness of adding dapagliflozin as an intensification strategy for patients with uncontrolled type 2 diabetes. The proportions of the patients achieving HbA1c target less than 7% was highest in the dapagliflozin add-on to metformin plus gliptin group. The addition of dapagliflozin for intensification of the dual therapy consistently improved not only the A1C but also the body weight and blood pressure, and this statistically significant results. See, we can clearly see the orange one, the first bar diagram orange is dapagliflozin add-on to metformin plus glibenclamide, and the second is the yellow, that is dapagliflozin added to the metformin plus saxagliptin, and the green is dapagliflozin add-on to metformin plus exenatide, and the brick red is the fourth one, the dapagliflozin add-on to the metformin plus insulin. You can clearly see the 12 weeks and the 24 weeks and the 52 weeks. The winner is definitely the dapagliflozin added to metformin and the saxagliptin. So the inference is that this is the best triple drug therapy, metformin plus DPP4 inhibitor plus SGLT2 inhibitors. The triple axle study confirms that the initial the triple combination the therapy effectively lowers HbA1c with higher tolerability and safety compared with conventional stepwise treatment in drug-naive patients with recent onset type 2 diabetes mellitus, and 105 patients aged around 18 years and adequately controlled were randomized to the TCT group, that is the triple combination therapy, 1000 mg of metformin, 10 mg of dapagliflozin and 5 mg of saxagliptin once daily, and the CST group, that is conventional stepwise therapy, metformin followed by glimepiride followed by sitagliptin sequentially. The primary outcomes, the proportion of patients who achieved HbA1c less than 6.5 without hypoglycemia, weight gain around or more than 5%, and discontinuation due to adverse events at the week 104 actually. On the right hand side you can see it's a multi-center randomized 104 week open label active control trial conducted at 9 medical centers, and on the left hand side you can see the bar diagram, the blue one and the orange one, the patients who achieved who achieved primary outcome, and the next is the patients with hypoglycemia, weight gain of more than 5% or discontinuation due to adverse event. This is the blue is the triple combination therapy, and the red is the conventional and the sequential therapy. So you can clearly see the difference between the conventional and the triple drug therapy, which is far more superior to the conventional stepwise therapy. And in this drug-naive patients with decompensated T2DM, initial triple therapy using SGLT2 plus DPP4 inhibitor plus metformin results in sustained rapid and satisfactory glucose control. This is the 2-year therapeutic efficacy can be seen in the graphic representation on the right hand side and the left hand side. And the target goal achievement rate is more than 70% for glycemic target after the initial therapy. You can clearly see that the A1C less than 7% on the left hand side, and the A1C around less than around or less than 6.5 on the right hand side. You can clearly see that the 74.5% and the 72.5% were able to achieve this A1C goal of 7%, starting from the 0 and the second month and the 5 months and the 12 months and the 24 months. And the favorable alterations in the body composition with initial triple drug therapy, which reduces the body fat and increases the muscle mass. This is the greatest advantage of this particular combination therapy. The synergistic effect of fixed dose combination triple drug therapy with the SGLT2 inhibitor and the DPP4 inhibitors plus metformin tackles the various pathophysiological targets in the type 2 diabetes. That is the classical the classical ominous octet of the pathophysiological changes of type 2 diabetes described by my mentor R.A. DiFranco, Ralph Anthony DiFranco, ominous octet. So the SGLT2 inhibitors and the DPP4 inhibitors and the metformin, they act the causes for this hyperglycemia may be at the level of liver, at the level of pancreas, at the level of muscle, at the level of brain, kidney, and the gut, and the adipose tissue, and the pancreas. So these are all met with the combination of the ominous octet is effectively countered by this particular combination of metformin and the combination of DPP4 inhibitor and an SGLT2 inhibitor. And fixed dose combinations, FDCs of dapagliflozin, sitagliptin and metformin in patients with type 2 diabetes poorly controlled with metformin. So, triple drug FDC once daily was significantly better in achieving glycemic control versus dual combination once daily in patients with type 2 diabetes poorly controlled with metformin without any significant safety concerns. And one thing in this context, I would like to tell you that though the trials are done with saxagliptin, later on the SAVAR TB58 has shown that the saxagliptin has got a little tendency to induce the heart failure. So it is almost out of the market, and wherever there is a probability, you should avoid it. So we don't know. See, heart failure is a sign of insulin resistance actually. So we don't know whether the patient has got clinically in the busy schedule. You cannot make out heart failure, whether it is present or whether it is established heart failure or at risk of getting heart failure. So it's always better to not to take a chance with the saxagliptin. You please avoid it. So you can go for the vildagliptin or the sitagliptin or the linagliptin. And one more happy news is that the empagliflozin is going to be off patent by next month, that is March 11th. It is going to be off patent. We can see the drastic fall in the prices actually. Already there are 1-2 molecules already present in the market. Unethically they have come into the market actually, and the Boehringer Ingelheim people have filed cases against that. But anyway, by March 11th, everything is null and void. Anybody can come with linagliptin plus the empagliflozin combination at an economical price. We can expect. Oh, no. Wow. Okay. Good. So the MESDIA trial confirms the superiority of the FDC of the dapagliflozin, sitagliptin and metformin compared to dual therapy in Indian adults with uncontrolled type 2 diabetes, that is A1C of more than 8%. And you can clearly see that the triple drug on the left hand side, you can see the triple drug and the dual drug. You can see the difference also, and on the right hand side also, the left hand side indicates the A1C post treatment, and the right hand side that bar diagram shows the change in the postprandial glucose post treatment. And the economic evaluation of the diabetes treatment in India, importance of cost effective fixed dose combinations actually. The fixed dose combinations, that is the FDCs, they are going to reduce the pill burden, the polypharmacy on one hand, and on the other hand, the price is also very much reduced. Suppose you take this the molecule from Reddy Labs, the dapagliflozin 10 mg with sitagliptin 100 mg plus 1000 mg sustained release of metformin or 500 mg of sustained release of metformin is costing around 13 rupees 33 paisa. See, I had been prescribing all these ever since the triple drug has come into vogue, starting with vildagliptin, dapagliflozin and metformin, and the sitagliptin, the dapagliflozin and the metformin, and it is available at as low as 13 rupees. The newly diagnosed drug naive patient, the de novo patient comes to you. So they are available at as low as 13 rupees. So you can never imagine a triple drug, that is a DPP4 inhibitor and metformin and a combination of SGLT2 available at such a low price. So this is going to cut the cost of the burden of the treatment of type 2 diabetes. in our country especially. The economic menace of diabetes in India, the cost of the diabetes in different north, south, the east and the central part and the western part. Say systematic review of 32 studies indicate that the median direct cost of the diabetes per annum is estimated to be, the northern zone is 18,890 per annum. The south is 10,585. I don't believe in these figures actually. So every patient of mine is purchasing the 1 month course at not only the diabetes actually. There are so many comorbidities, like once there is type 2 diabetes, automatically the comorbidities is the hypertension and associated dyslipidemia, and the patient will be having the hypothyroidism, which is not a costly affair actually. So the LT4 is the cheapest molecule that we get in India, and other complications like the sensory neuropathy. The cost of the complications is more than that of the cost of the therapy actually. The northeast zone is 45, that is almost 46,000 per annum, and western zone is 8,822, the least. I don't know the reason why west zone is showing so low expenditure on the cost of therapy for type 2 diabetes per annum. And the need for cost-effective anti-diabetic therapies in India, probably the take-home message, as diabetes is lifetime treatment, it comes under chronic therapy segment. The lifestyle diseases, all the lifestyle diseases, starting from diabetes to hypertension, they are all the lifetime diseases. The treatment effectiveness depends mainly upon the treatment compliance of the patients. In a developing country like India, where the majority of the population comes under a lower socio-economic class, cost of the treatment is one of the important factors affecting the treatment compliance of the patients. And it is estimated that low income families, the cost of the diabetes treatment for an adult diabetes is up to 25% of the family income. Yes, this is exactly true. And sometimes it is even the half of the family income. Suppose the patient lands up in gangrene and he wants to go for the limb amputation, actually either above knee or below knee amputation, that costs more and more. The cardiovascular events, whether the PCI with stenting or the cabbage, whatever it may be, that costs more. And the fortunate thing is that our state, the Telugu speaking states have got the Arogyasri facilities, wherein thousands of diseases are covered under that, and they are getting the free services actually. That is the good part of the Andhra and Telangana. And the anti-diabetic drug should be available in an affordable price to the majority of the population for better adherence to the treatment. And remember, the need is to lower the load of risk by accessibility, the affordability, and the adherence. And thank you so much, my dear doctors, for your patient listening. Now it is time for question and answer session, and if you can type your questions and put it in the chat box so that I can take up the question and answer session.